Is it not? Don't read me by now. Huh? Huh? On his phone? Are you there? Live now?
Yes, sir.
It's live now. Abi? Only an address. Eh? Live, Abi? Okay. So, good afternoon, everybody. I think there are two people here. All right. Mela Degbite, she's the other person. I may have to, Ogunigbe, please, you might need to sit here because you need to help me with the board. I need him to see. Now, please shift. Let him sit here. Abi, is it okay there? Thank you. Now, so we have some everybody. We have like 1 hour to go before I have to get to the next class. Today, I don't am here. You don't pass it. Now, I said last week, for those that are in class, I started with respiratory system. So we're looking at drugs used in your respiratory system. Now, we have to understand the organs in the system, right? The organs in the system, which would be majorly our lungs, and in a way, it will be linked to blood supply. But finally, we want to look at some of the disease conditions here. And when we look at the respiratory system, for the problems here, we can divide into upper respiratory and lower respiratory tract. So we can divide here. So depending on what we are talking about, that would determine the conditions we will discuss. For the lower respiratory tract, we can look at the asthma here. We're talking about asthma here, and COPD here. For the upper, probably things like cough, rhinitis, etc. That's what we look at there. So you will see that I won't mention this condition, this bacterial. I won't mention pneumonia or tuberculosis because that is not really within the scope of what we're doing now. We want to look at majorly these cases. So whereas I would love to jump the introductory part that these conditions are serious, and this is what is the C for? Chronic, meaning that it's not acute, it's not what you find in a patient today and it stops tomorrow. It grows and it gets worse with time if you do not manage them. That is the issue. So at times you might find patients with asthma, at other times you find patients with COPD, at other times you find the overlap of what asthma and COPD in patients. That is just around that is for the hospital to determine. But here we want to look at the asthma and COPD. So I want to limit my work to the drugs used to treat asthma. The drug used to treat asthma. So although we're supposed to discuss the symptoms you see in asthma, that for asthma, that asthma is characterized by a recurrent bout of coughing. You see that the patient or the person have to cough a lot. There's coughing, there's wheezing. Wheezing, it makes a sound. There's the shortness of breath, and there is the tightness of the chest. What we have there, what you have is more or less an inflammatory condition, an allergic condition that has developed into all of those things. There is coughing, there is wheezing, there is shortness of breath, there is difficulty in breathing, right? So why do the patient have all that? So what started was allergy. something triggered all of that. So, but by the time you get to see the response, it's usually along the late stage. Now, once the patient begins to wheeze, what you're saying is that the person cannot breathe. Person cannot breathe well. Person cannot inhale deeply and exhale. So, at the time, you are dealing with two things. One, what is what? The allergic reaction, where you may want to use antihistamines and other words just for allergy. The other time is you now want to allow the patient to be able to breathe properly. Is that okay? So, have you seen, most of you have seen an asthma, I don't know if there's an answer question in this class now or up here. When you see anybody with asthma, have you seen them giving them histamine, ibuprofen, antihistamine? Why? We said it's an allergy. Do you understand? It's an allergy, right? So if someone has an allergy and has some of those things, should we not give the person antihistamine? But the point is, at that point, it's already too late to be giving the person with antihistamines. So we say that you give antihistamines or any drug for allergy, you use it to preempt or to prevent the development of an allergy. Once the allergy develops, at that time, you are trying to find ways to ensure that that person survives the allergy. Do you understand? So when you see people with asthma, because at the time you see them, they cannot breathe. What you have to give them is a drug that helps them to breathe. A drug that helps them to breathe. So it's when they are still alive that you can now treat allergy. Do you understand? So that will now determine the type of drug we are going to use. So I said there is a cough, there is a wheezing, there is a difficulty in breathing, there's also chest tightness. So we want to give drugs that can relieve all that. Now, moving on from that, I want to jump the factors that may trigger, but I want to just focus on the drugs. Now, there are two classes of drugs we use to treat either asthma or COPD. Two classes. One class are simply called bronchodilators. Are we okay?
Yes, sir.
One class of drugs are called what? Bronchodilators. The other class will be, I think it's as anti-inflammatory agents. We have two classes of drugs here, a bronchodilator or what? An anti-inflammatory agent. Right? So I wrote that the main treatment aims for asthma control are as per this nice, that you want to ensure that there are no daytime symptoms, no nighttime waking up due to asthma, no asthma attacks, no limitation of activity, no requirement of rescue medications. Several classes of drugs are used. Number one, we have a class called bronchodilators. And usually we call them relievers. Relief. Bronchodilator will relieve asthma or COPD. The second class of drug that you can give it are what we call a corticosteroid. Corticosteroid, which are what we call preventers. So a bronchodilator will relieve the asthmatic condition. Your anti-inflammatory agent here will prevent. So here I mentioned a corticosteroids. Do you understand? So the two classes is either the drug is what? A bronchodilator, or the drug is what? An anti-inflammatory agent, basically. Now, I said that, now, if you look at reliever, you want to relieve, you want to prevent. You cannot prevent asthma when the person is already coming down with what? Asthma. You prevent asthma when the person is what? Normal. So you are preventing asthma because you don't want the person to have asthma. Do you get that? So if you understand, the time you should give somebody what? A corticosteroid. When the person does not have, to ensure that the person does not have. When the person has, you can no longer give what? This, because it's not preventing anything again. The person has to be alive first. They now do what? This one. So at the time the person has an acute, because there are chronic conditions, but there are plenty of acute symptoms, right? So when the person has the acute symptoms, you want to give what? A reliever. So it's when the person gets relief that the chest tightness will reduce, coughing will reduce, right? What does again? Breathing will stop. Because at the time, what you find is that I showed a picture. I think that was I sent. Please remind me. So I was shared. There was a note I shared on this. I sent last week. There's a note I made on this that when you look at a normal person, when you look at the bronchioles of a normal person, check your Olympic course. The lumen will look like this, large, for air and everything to pass through. In an asthmatic person, that's supposed to look like this, right? The lumen can be as small like this. Do you get the difference? Yeah. Let me shade out. Lumen is like a passageway. In a normal person, the space will look like this. So you breathe properly. You can run, do your exercise and all that. When a person has asthma, the person has this. So we say that bronchoconstriction. One point is what? There is what? Bronchoconstriction. So once there's bronchoconstriction, the muscles tighten up. So, and these are smooth muscles. That's what we are doing what? Smooth muscles. In the body, we have three muscles. We have the cardiac muscles. This, we are still coming back to the cardiac, smooth, and skeletal. So in this area, we are not doing the skeletal or cardiac. We are just doing what? The smooth muscles in the lungs. So most of the drugs we are looking at are drugs that are smooth muscles in the lungs. So it means that what if that drug acts on the smooth muscles of the lungs, and for some of the other smooth muscles in other to our body, like in your intestine now, right? If those drugs, if their receptors happen to be along the intestine, so this same drug can act on your lungs or in your bronchioles and also produce effect there, depending on the route of administration. Is that understood? Yes. Do you know what I just said now? Yes. If I give you a drug, now some of these drugs, you see that they're not only used here. So the route by which we give it here determines where we really see the effects. Do you understand? Yes. The route by which we give it determines where we really see. So if we want to localize the effect, that is the point, to the respiratory tract. So to localize the effect, we cannot always give it via a systemic route. Do you understand? Yes. Except we want a broader effect. So if you give the drug via a systemic route, what do you expect to see? You expect that what? The onset of action will be delayed. Do you understand? Yes. The onset of action will be delayed, but now you have more diffused effects. Do you get it? So I said we have what? A bronchodilator, we have an anti-inflammatory agent. Then the other group of drugs I mentioned them just for maintenance and relieving. We have other data, but majorly they will fall under here, either a bronchodilator or an anti-inflammatory agent, right? Now, I want to discuss bronchodilator. That is why I came to use the board. If you got this, and I have to clean everything I have on the board again to discuss what the bronchodilators get. So I believe in probably your message or that you have discussed on, you know the pathological conditions here. So the symptoms we find. Now to discuss the bronchodilators. Majorly, please, you need to get this. Although it's not there, I'm bringing a lot of information down to this place. Is this still live? Are you still?
Yes, sir.
Right. Now, in our body, we have what we call what? A nervous system. A nervous system, right? Our nervous system is divided into what? The central nervous system and the peripheral nervous system. Are we together? Yes, sir. So our peripheral is none of our business right now. Our focus is on on our peripheral nervous system. Our peripheral nervous system we can visually divide into two areas, right? Yes, sir. What are they?
Autonomic and somatic, yeah.
Jesus. autonomic nervous system and somatic nervous system. Somatic innervates what? The skeletal muscles. So we don't really have business with this side for now. Somatic nervous system and the autonomic nervous system. Autonomic nervous system, everything that is not under your free will, under your direct control, will fall under the autonomic nervous system. Is that okay? So for autonomic nervous system, we still have two here. So we discussed what here? Sympathetic nervous system and what? And the parasympathetic nervous system. If you don't know, this matter is much more clear. Okay, we have these two systems. Can we still go further?
Yes.
What would we have now? No, somewhere here, now we have the afferent neuron and the efferent neuron. What else? What is the next? Can we still go further than this? Okay. Now, look at these two systems. Sympathetic nervous system and the parasympathetic nervous system. As I'm standing up, I'm in a standing position and I'm walking. My sympathetic nervous system is much more active than yours sitting down because I'm in a much more active position. Majorly, what we know is that most of our daily body activities are under the control of the parasympathetic nervous system. Everything we do normally, breathing, digestion, name it, under here. The sympathetic would tend to override para when there is a need to increase public energy demand, your stress level, when you need to be much more alert. But generally, everything is under here, mostly controlled by this. So it means that what your breathing is controlled majorly by this system. Digestion is controlled mainly by this system. Even your heartbeat is controlled by this system. This one too can control them, but this one would only override what this system is doing when you are under stress, when you need to fight, when you need to flight, when you need to freeze. You know that response. That's when sympathetic will normally override this. So I used to make a joke. I said, probably you are trying to give birth now, or maybe you want to use the toilet. You feel you are pressed, you have running stomach, and you are bending down, and you see a big snake or a lion, you hear the roar. All that stimuli to defecate will stop. You will start running for your life. But at that time, what is more important is for you to stay alive. You thought you cannot hold the feces. No, the thing was almost dropping. You were even doing like this in toilet. You met a lion or tiger there. That thing will stop. You push it back. You push it back and you start running. So maybe by the time you get to like 2 km from here, you're now okay. All of that stimuli to use the toilet will now come back. Because at the time, sympathetic nervous system override what was happening because there was a need to survive. Do you understand? So digestion at that time, digestion would drop, right? Your digestive system, everything in the digestive system would reduce because more blood will now have to move to your skeletal muscle, to your heart, to your brain, because you need to survive. Do you get that? So now, for the parasympathetic nervous system, for every nerve system has a nerve. For every nerve, there must be a neurotransmitter. Every nerve has a neurotransmitter. Every nerve has its own neurotransmitter. Every nerve has its own neurotransmitter. So, for the parasympathetic nervous system that has nerves, vagus nerve, you remember vagus nerve, right?
Yes.
The longest, right? On the track. So, this parasympathetic nervous system has a nerve, and the neurotransmitter mostly is what we call what? Acetylcholine. Acetylcholine is the major neurotransmitter that is released via the parasympathetic nervous system. Whereas for sympathetic nervous system, what is released is what we call noradrenaline. If you get my explanation, you understand the drugs. When I start the drugs, it will be easier for you to understand them. Noradrenaline here, acetylcholine here. I didn't put adrenaline because adrenaline is mostly in the periphery, is what? And the moon. In the CNS, you have it in some areas as induction. So we have noradrenaline here, we have acetylcholine here. Is that understood? Now, there's something called NMJ, neuromuscular junction, neuron and muscle at the junction. Neuron meet muscle, neuron meet muscle at the junction. We call it neuromuscular junction. Neuron and muscle. There's a junction, but we'll get back to that. So we have this. So I simulate this nerve. The nerve releases what? Acetylcholine. This one is what? Noradrenaline. So we now need to understand where does the nerve, the nerve, right? The nerve must affect any effector, right? Sense organ has what? Is this afferent now?
Yes.
Afferent neurons, sensory neurons. Your organs that tend to react have what we call what? Motor neuron or efferent neuron. So for the nerve, I don't want to draw the structure, that release a neurotransmitter, there must be, once it's released, where is the action? Where will the action terminate? What does it influence? Right? So if I'm coming to put my hand in your eyes, unconsciously you blink. You don't even get to move your hands because you have not been trained. You've not been trained to do that, right? But unconsciously you blink because that is the normal response to me trying to poke your eyes, and your eyes can see. Tell me your brain really that someone wants to poke, so you need to blink. So here we are looking at that there are also receptors that these nerves would affect. There are receptors for acetylcholine. There are receptors for noradrenaline. Are we together?
Yes, sir.
So mostly your acetylcholine, when it's activated, we either bind to what we call nicotine, nicotinic receptors, or the muscarinic receptors. These are receptors. So usually you find this one centrally. So all of it that smoke, contain nicotine. That contain nicotine. You expect that what? The nicotine in that thing you are smoking would affect your nicotinic receptor. So also affect your parasympathetic nervous system. So the reason why when you smoke igbo or cannabis, the reason why you cannot use the toilet, the cannabis one way or the other affects the parasympathetic nervous system and causes them to shut down. So there is no mobility, there is no secretion. We'll get back to that one later. So if you understand what we have muscarinic receptors here, we have nicotinic receptors here. Are we good? I don't want to go into maybe M1 to M4, but know that what we have muscarinic receptor here. For what? Acetylcholine for parasympathetic nervous system. Nicotinic, yeah. But we're not talking about because it's usually found centrally. Central is what? Brain and spinal cord. Here you can find this one also in the periphery, right? For your noradrenaline, it will bind to what we call what? Adrenergic receptors. Adrenergic receptors. Are we good?
Yes.
Noradrenaline binds to adrenergic receptors. Histamine binds to histaminergic receptors. Right?
Yes.
Serotonin will bind to serotoninergic receptor. Dopamine binds to dopaminergic receptor. Right? GABA will bind to GABA receptors. Right? So when you look at adrenergic receptor, we have two types here. We have what? Alpha receptors, alpha in Greek, and beta receptors. We have what? Alpha receptors and beta receptors. Are we good up to this point? We have alpha and beta receptors. Now, For your alpha receptors, I said these are what? Adrenergic. Alpha receptors, we have alpha 1, we have alpha 2, we have alpha 3. For your beta receptors, we have what? Beta 1, beta 2 receptors. Major beta 1, beta 2. Are we still on the same page?
Yes.
Okay. So, what do we find alpha 1? What do we find alpha 2? What do we find alpha 3? And where do we find beta 1? Where do we find beta 2? And where do we find beta 3? We find majorly along your blood vessels. Is that okay? We'll find your alpha 2, what I tend to do, which might not be so important now. The alpha 2 tend to have what we call a modulatory effect. It can have a positive effect, it can have a negative effect, depending on what you are. When you activate it, whatever you're doing, whatever adrenaline, other things are doing, alpha 2 tends to modulate them either positively or negatively. Do you get it?
Yes.
So, but majorly, remember what alpha 1 are found majorly on blood vessels. And this is the only place, majorly on blood vessels. So, and these blood vessels they have smooth muscles. Please get it. Vascular smooth muscles. Your blood vessels have smooth muscles. So if it doesn't have a muscle, it may not be able to contract or relax. Do you understand? The reason why people can have hypertension is because the blood vessels, tension is the force. They have muscles that can react both ways. Now, your beta 1, majorly in the heart. Beta 1 receptors are found majorly in. So that is what? Cardiac muscles, right? And we're not here to talk about cardiac muscles today. Then are we talking about the skeletal muscles? We are basically talking about smooth muscles. So your beta 2 are found generally on smooth muscles. No, I didn't say respiratory muscles. Generally smooth muscles. So wherever you have a concentration of smooth muscles, you will find what? Beta 2 receptors there. Do you get it now? So you can give a drug to, now let me say a woman or a lady, for example. You can give an asthmatic patient that is a lady a drug via maybe the oral or systemic route. The drug can affect our respiratory system, also affect our reproductive system. Because they are also used on smooth muscles in the reproductive tract, at times to delay parturition, giving birth in women.
Yes.
To delay it. So you are thinking, what's the connection? So the point is for you not to cramp the drug. For you to understand why the drug can be used here and used here. So I'm not talking about drug now, because when I start talking about the names now, you might get confusing. So what I've talked about is what I've talked about. What you find that we have a nervous system that works everywhere in your body, that are basically under autonomic nervous system, your para and your. So under your paravenous system, what we are concerned about here is just the muscarinic receptors under the para. But under the small nervous system, what we are concerned about really are the adrenergic receptors. But basically, it will now be beta 2 receptors. So what am I trying to say? When you give a drug that acts or looks like adrenaline, when you give a drug that behaves like adrenaline, so I said noradrenaline is the neurotransmitter here, right? Majorly, what you tend to, as a form of drug, what you tend to do is more or less, the drug must be like adrenaline. So non-adrenaline behaves like what? Adrenaline. Adrenaline in the body as an hormone, but also centrally, in the central is not hormone. In some areas, we have it as what? A neurotransmitter. But generally, what we have as a neurotransmitter in this system is what? Non-adrenaline or epinephrine or non-epinephrine. Epinephrine is American, adrenaline is British. Do we understand up to this point?
Yes, sir.
So it means that what? If I give you a shot of adrenaline, the effect I see or the effect I get from adrenaline depends on where the adrenaline binds to. That's what I need to understand. If I give you adrenaline, the effect I get depends on where the adrenaline binds to. So if the adrenaline binds on your alpha 1 receptor, it affects your blood pressure primarily. Do you get it now?
Yes.
If it comes on your beta 1, it affects your heart and your blood pressure. If it binds on beta 2, it affects smooth muscles primarily. Do you understand? So when you have your adrenaline also bind, once you have this when you activate alpha 1 receptor. Now this is the next step. When you activate alpha 1 receptor, do you understand?
Yes.
What you normally get is what we call vasoconstriction. When you activate alpha 1 receptor, what you will normally get is what? Vasoconstriction. So if you think you are normal now, if I give you adrenaline injection, it affects your blood vessels. What happens to you? Your blood pressure will rise because of vasoconstriction. Vaso is what from blood vessel, constriction of blood vessel. So when you constrict the blood vessel, the heart has to work harder to pump blood. So blood pressure indirectly will rise because what? You have constricted the pipe where the heart is pumping blood through. Do you understand? If you don't understand it, you get back to that under cardiovascular system. Now, beta 1, 2. When you activate beta 1 in the heart, you also produce the same effect that the heart will beat faster and more stronger. More strongly rather. In the heart, do you get that? So when you say adrenaline pumping, when they used to say it, so the effect is not only on the blood vessel, it has the blood vessel constriction affect the heart. That the heart can beat faster. Beating is not only beating faster, it's beating harder. So it can pump blood faster and more strongly. You get that? We call it increase in chronotropic effect and inotropic effect. But that's not for now. Chrono means time. Chronos means time. Ino means pressure or force. So when beta 1 is activated in the heart, what tends to happen is what? Increase in the rate is time, increase in the force. So a person that has high blood pressure should not be given adrenaline. That's anyhow. So you now understand why adrenaline is given to people that are about to die.
Yes.
In emergency situation. Maybe when they have this allergic condition. What we call this serious allergic condition. What's that again? Maybe they have it's not just shock now. Anaphylaxis. Once they are in anaphylactic shock, they tend to give them not only antihistamines, they also give them adrenaline. Why are you giving adrenaline? For all of these reasons. That it will increase the heart activity, the blood vessel, and the person will now be more alert. And when if they need to torture you too, you can use adrenaline to torture you. You will not faint. You will not pass out. A backfire they give you, you wake up again. You start the beating and flogging again. But it's just so there are many ways you can use the drug. So, but on beta 2 now, so when we now activate, once adrenaline comes on beta 2, what it usually causes is what we call what? Smooth muscle relaxation. Do you understand? So on beta 2, here it said constriction. Here too, more or less increase. On smooth muscles, it cause what? Relaxation of those muscles. It reduces contraction on smooth muscles. If you get this, you will not have problem with the drugs we are going to talk about now. That if adrenaline gets to smooth muscles, or a form of that, when you activate beta 2 receptors on smooth muscles, what you have is what? Relaxation. The muscle will relax. So now that we are dealing more or less with the lungs or respiratory tract, we are looking at what? The bronchos, the bronchial, and all of them. So what we have here is what? Bronchodilation. What we have is what? Bronchodilation. I cannot be talking of uterus, I'm saying what? Bronchodilation in the uterus. That's I said what? For smooth muscles, you have what? Dilation or relaxation of smooth muscles. For smooth muscles, B2, when you activate them, what happens what? Relaxation or dilation of those smooth muscles. Now, depending on where you need relaxation, so now that we need relaxation or dilation along the lungs, okay, we can activate them there, and now we now have what? Bronchodilation. Are we good?
Yes.
Why do we now have to activate this? Because asthma or COPD that comes with cough will cause bronchoconstriction. Is this simple? This is not right. Asthma will cause bronchoconstriction. Apart from wheezing, cough, it tends to cause it causes secretion of fluids.
Yes.
A lot of secretion of fluid. So that's why those people cannot breathe. They are beginning to choke. Right? So now that the person cannot breathe, we need bronchoconstriction to stop. We need what? Bronchodilation to start. So if you don't stop bronchoconstriction, the person will die. So that's like any asthma drug you see, go and check it. Those are usually what? Bronchodilators. When you give it for the bronchial muscles, you take on that smooth muscles, the point is it's producing what? Dilation or relaxation of those muscles. Do you get to this point?
Yes, sir.
Do you get to this point?
Yes, sir.
Now, another rule of thumb, whatever you see your parasympathetic doing, sympathetic nervous system usually will do the opposite. Get that? Parasympathetic nervous system and sympathetic nervous system, they are like word and opposite. So if one say man go, the other say what? Woman come. Man go. Next one, woman come. You get it?
Yeah.
And they tend to reverse them. So the point is, so when your parasympathetic nervous system wants to maintain your blood pressure to a particular level, I said your normal functioning is what? Parasympathetic nervous system. So when you inject someone with adrenaline, you're not trying to maintain blood pressure again. You get it?
Yes.
It will override what parasympathetic nervous system, so which was maintain blood pressure at maybe 110/70 and shoot it up. You get it?
Yes.
So why should you understand this? Because when you talk about drugs that act on these systems, drugs that act on this system will produce opposing effects. A drug that behaves like what? Acetylcholine would increase secretion everywhere. A drug that behaves like acetylcholine would increase secretion everywhere. Your eyes, your nostrils, your mouth, your esophagus, your stomach, your large intestine. It will increase secretion and increase movements. Yeah. So if you understand, so when we get to some of those things, so if a drug has some personal secretion, that's why you can go to toilet because you want to go and defecate or you want to go and pee. Because paraspinal system is telling you the food has moved down, now you need to go and do this. So once you see an emergency or something about to happen, what is the expand the muscle, the muscle, then it has like a gauge along the neck. I don't know what we should call it now. Like some of these valves in the heart, a sphincter. So the point is, when you need to urinate, your sphincter will relax. The descending muscle would contract. You get it? When emergencies happen, your descending muscle will now relax. Sphincter will tighten up. So most times, when you consider the effect of what? Sympathetic and parasympathetic, they tend to be opposite in nature. Is that clear? Yes, sir. So I said that what? For beta 2 here, we need what? This one we call bronchodilation. Right? So it means that, so and here, adrenaline will be an agonist here. You get it? Adrenaline or any other that means that it will be what? An agonist here. Is an agonist here. So if an agonist from the sympathetic nervous system, this is advanced pharmacology, get it? If an agonist from this place causes relaxation, usually is an antagonist from this system that will cause relaxation. You won't find it in most stuff. You have to read and compress information. This is not what the drug does. This is not about drugs now. This is about what? Human or animal physiologically. When we say agonist, I'm talking about what? Pharmacology, drugs. And those drugs tend to behave like what? Endogenous ligands. Do you understand? Yes, although we produce the drugs, they are behaving like what? Endogenous, what you find in your body. Endogenous ligands. So drugs that act on this system tend to behave like adrenaline or either agonist or antagonist. Right? So drugs that act on this system tend to behave like acetylcholine or the antagonist of acetylcholine. Are we still together? So I said B2, activation of B2 receptors will cause what? Relaxation or dilation. I said here, usually is the agonist, because adrenaline is an agonist there. So you're not giving adrenaline to the person. I mean, if someone has asthma, I give person adrenaline to the name. You won't give adrenaline, but you give drugs that may behave like adrenaline. So we call it sympathetic system, mimicking sympathetic system, mimicking sympathetic nervous system. You can hear sympatholytic, which should be now the opposite of sympathomimetic. Are we together? So if you get this now, I may now want to move to the bronchodilator again to discuss bronchodilators. Are we good? So, where's my duster? You'll find it in textbooks, either American or British. You see sympathomimetics. I'm saying sympatho from the word sympathetic nervous system, mimicking. You see it a lot, even with psychotomimetic. By the time you get CNS or go to Arrow, psychiatric hospital, you say psychotomimetic, psychedelics, psychotomimetic. Those that mimic or that affect or influence cerebral activity. Now, having discussed this, we now talk about our bronchodilators. Smooth muscles. So the point is what? They are dilators of smooth muscles. Dilators of smooth muscles. Dilators of smooth muscles. Now, looking at this, drugs that you give as bronchodilators the treatment of asthma, there's a class of drug here called we call SABA and La. The other group, SAMAS and La. Now, there is an acronym which I'm trying to define. You remember it, you remember almost everything you need to remember the drug. This class, I recorded a video of it on YouTube, Respiratory System, where I want. I'll go and read. If you like, don't go. I'll just go and search. You find it. Now, what is the SABA or the LABA? SABA stands for short-acting beta-2 adrenergic agonist. So what do we have here? We have short-acting or long-acting beta-2 adrenergic agonist. This should make sense now with all I've explained so far. Then the only part that I know this is short, long and short. Beta-2 adrenergic agonist should now make sense. I said beta-2 is one of the adrenergic receptors. Beta-2 majorly for smooth muscles. So, this drug or any drug you find there, either short or long acting, is an agonist at beta-2. Agonist at beta-2 adrenergic receptors. So, what do you expect it to do? Bronchodilation. So, when we say short acting or long acting, we now begin to, what do we mean? This is the rule of thumb. Depending on it does not apply to all drugs. When I say short and long, it's relative. If you say I'm short, you can say I'm short. Some people think I'm long. Like maybe I'm too short, maybe I'm just tall. Some say I'm average. Depending on who you are comparing me with. You can use someone that is here beside me, I am tall. If the person is just here, I am tall. If you put a draft beside me, I am tall. Because the draft will at best be here. The draft should not pass this level. So if the draft is here, he has to look up at me. So I am definitely tall. You put me beside some giants, or some people that have acromegaly, all those issues that tend to be tall than giants, really. And the person is about 3 meters, 2 points, maybe 2 meters, 2 points, no, almost about 3 meters tall. I have to do like this. So the person is almost up there. So I'm definitely short. You stand for, if you watch basketball, LeBron James, right? LeBron James is very tall. Yeah. And most people are just, first time said, probably, if I am playing, I will just be at most. I don't think I will get up to this level. So, depending on who you're comparing him with, I am tall or short. Tall or short, right? So, but for drugs now, why did I say that? For a drug, when you say a drug is short acting or long acting, short acting or long acting, it depends on what you are comparing with. A drug can be short acting and the drug only lasts for 30 minutes. You get it? And even the one that is long acting there, then the drug only lasts for like 2 to 3 hours. So we're not saying that when a drug acts for 30 minutes, it is what? Short acting. That's what I said. I'm saying in context of what you are comparing it with, we do not what short acting and long acting. Because the one that asks for probably 2 hours, digoxin has an half-life of, it's not 48 hours, 24 to 48 hours. That's what I remember. Digoxin or digitoxin. No, digoxin is, oh no, I remember. We have digitoxin and digoxin is just off this CNS and CVS. We say digitoxin is long acting. We say digoxin is quick acting. Long acting means it may work for over a day. But that is almost 48 hours. 48 hours. The one that is short acting for probably for like 8 or a quarter of the other one, just for some hours. Do you understand that? So now we cannot import that to this. Because when I say short acting here could just be like 30 minutes max. Now the point is this: when you have an emergency situation, what type of drug do you use? A drug that is short acting or a drug that is long acting?
Short acting.
So this is it. If a drug is short acting, right?
Yes.
We are saying now what? Duration of action. Duration is what? Short. Onset is fast. Do you get that?
Yes.
When a drug is short acting, duration is short. The most important part of it is not the duration, is what is the onset. Now I give it now, within a minute or two, I begin to see the effects. So when a drug is long acting, duration will be long. Onset is delayed. Do you get it now? So here, duration of action can be 30 minutes. Onset can be 2 minutes, less than 5 minutes. This is what you need in an emergency situation, like asthma. You don't want the person to die. If you give a long-acting drug, duration can be maybe 8 hours, and onset can be like 30 or 1 hour. 1 hour. The person may be dead. Do you understand? So, it's common sense, which you find in textbook, which you can always think. There is a time you will need a drug that acts long. So, when you need a drug that acts for long, is when I want to, just like when I mentioned what drugs that prevent and drugs that relieve. When I give a drug that has a long duration of action, I'm trying to ensure that what this thing does not happen for the next 10 hours, for the next 1 day. Is what we call maintenance. I'm trying to maintain you in a stable condition. To stop you from dying first, from bronchoconstriction, I'll be giving what? A short-acting drug. After I've given you that, I can now introduce what? A long-acting drug. I'll tell you the next day. Do you understand it?
Yes.
But it is still what? A bronchodilator. A bronchodilator dilates the bronchus. A bronchodilator dilates the bronchus. A bronchodilator causes what? Bronchodilation. If you forget it. Okay. So, short-acting, long-acting. So, most of us you know salbutamol, right?
Yes.
Do you know salmeterol?
No.
I know you know salbutamol. This marker, you need to get a new marker. Salbutamol, or do you have another marker there? You have salmeterol. We have albuterol. Now, albuterol is short acting. I want to give you salmeterol. Classically, albuterol is what? Short acting. Salmeterol is what? Long acting. Short acting, beta 2. I think I'll say beta. Beta 2 adrenergic agonist. So once you now want to talk, if you remember albuterol, there's albuterol. Remember what? It is a SABA. You are already describing a drug. The other what is short acting, right? It acts on what? The beta 2 adrenergic agonist. Duration of action is probably 30 minutes. Also, 2 to 5 minutes. You're talking about the drug?
Yeah.
Do you understand? That's what we want to talk about. Do you understand? So, if you understand that what? The SABA, LABA are like this. Because I have a class now and I'm going to change this. We now talk about what? The SAMA or the LAMA. See the same thing? receptor as SABA. But currently in your textbook, you see some albuterol as your short acting, your salmeterol as your long acting, and other examples there. Now, coming to your SAMA LAMA, actually some of them took them like 3 or 4 classes to understand it. That's what I'm trying to start from. So if you don't understand now, go to yourself. Yeah. So SAMA and LAMA, SAMA is what? Short, I just give you like, so that we don't be
5.
5. Short acting muscarinic antagonists. Short acting muscarinic antagonist. Long acting muscarinic antagonist. So from everything I will explain, you can talk about what this, because I explained that what the muscarinic antagonist came from what? Acetylcholine. Acetylcholine is a receptor, is the neurotransmitter that will bind to either the muscarinic receptor or the nicotinic receptor, right? And it's linked to which system? Parasympathetic nervous system. And I said, if sympathetic is saying what? Go, your parasympathetic is saying what? Usually saying what? Come. They usually produce what? Opposing effects, not the same effect. So one will cause meiosis, one will cause meiosis. So one will make your eyes to become producing this I said, no, you know now what you have drank and when the thing is working. And they said, slap me. You drink, they said, slap me. I can't feel it, slap me. I can't feel it. Why? Because it blocks your pain receptors and you go to the toilet, and this is not coming out. Block the parasympathetic nervous system. It's when you block parasympathetic nervous system, you tend to shut down the normal activities of the body. So if you decide to go and smoke a bowl of marijuana or cannabis, we can put this in, put your head, you will not feel the pain. Or the thing wear off. But you also suffer complications. Right? So I explained that what here we had agonist. So don't mix it up. Now I've gone so far to explain so that you should not be mixing what agonist here, beta 2 and then agonist what muscarinic antagonist here. And both of them are still doing what bronchodilator. But so that here an agonist produces it because that's what adrenaline does on beta 2 adrenergic agonist receptor. Here we need a short acting muscarinic antagonist. So example here is what we call, I hope I'm correct. Yeah. Tiotropium and ipratropium. Ipratropium. I hope I didn't mix it up. Please, let me confirm. Sama is what? Sama is ipratropium. This is, I don't know. Sama is here, Ipra, and this is what? Tio. Ipratropium. Tiotropium. Lama is long acting. Lama is tio. Ipra is your short acting. So when they ask you what is ipratropium, so you know you need to talk about what we did your under antibacterial, how we should do drug class, drug, MOA, indication, all of that. So tiotropium is the drug. The drug class is what? For ipratropium is what? Short is a muscarinic antagonist. Like it's a short act. By the time you define this, you have defined the mechanism of action. It's a short acting muscarinic antagonist. Okay. Like that. So thereby, once it binds to the receptor, it causes what? Bronchodilation. No nonsense. Why do I need to go and cram? Get it now. The endpoint is what? To cause what? Bronchodilation. But this is doing it by affecting the parasympathetic nervous system. This is doing by affecting what? The sympathetic nervous system. Via the receptors, beta 2 here, muscarinic receptor here. Do you understand? Muscarinic, so short muscarinic antagonist. So the SAMA or the LAMA, the SABA or the LABA. Are we together?
Yes,
Now, what I just explained, because with my notes, this might get from the notes. I've used like almost 3 or 4 textbooks to make this note. What I just made is from what's this textbook? Huh? The note I was sent is probably from Lippincott. This textbook, hey, pink, the one I showed about, it looks like Mustafa, reddish, I said it's no longer available. What's that textbook? That textbook, what's the name of that textbook? Told me, what's the name of that textbook? What textbook? The name is to fly from my head. Let me check your it's in your list of book. It's not so available. Trances. So everything I'm doing here in my notes here is just how trances simplifies for us, right? So we have what bronchodilators. We have what the sabas, lavas. We have the sama or the lamas. Then now, before I was going to say before trances was used, before we start using before we use it, because this one happened to be safer and much more effective. There was a drug that was used as a drug before this one. We call them methyl. I've heard of them aminophylline, theophylline.
Yes.
It's still in use now. Just that the safety, the therapeutic index is very, very narrow. So I think you have to be careful when you give it to children. So before we gave this, the drug that was used were your aminophylines. So aminophylline issues, right? So I've discussed briefly your issues, right? So I've discussed briefly your I discussed your and your Saba under our right? I didn't touch an anti-inflammatory agents. Just the bronchodilators. I didn't touch so but on your aminophylline, yeah, I wrote about the most widely used xanthines are your aminophylline and your theophylline. So methylxanthines, aminophylline, theophylline, they are also bronchodilators. Methylxanthines, this group of drugs inhibit a family of enzymes called phosphodiesterase 3 and 4, PD3, PDE3 and 4, causing them to elevate the levels of signaling molecule called cyclic AMP. So the point is, once any drug that can increase the level of cyclic AMP, please get the name marker from there. We have ATP, adenosine triphosphate. When you disphosphorylate because of ATP, adenosine diphosphate, you phosphorylate again because of AMP. So the energy we use there, cyclic AMP. So any drug that usually that will increase this usually will cause bronchodilation. We get it. So this group of enzyme, this group of drug inhibits a family of enzyme called phosphodiesterase 3 and 4. Methylxanthines, talking about methylxanthines, the drugs here, they inhibit a family of enzyme called what? Phosphodiesterase 3 and 4, which are found on bronchial smooth muscles. They are found on what? Bronchial smooth muscles, causing them to elevate the level of signaling molecules, the cyclic AMP. Now, we talk about cyclic AMP in Pharmacology 1, when we talk about G-complex receptors, right? Cyclic AMP, cyclic GMP, inositol triphosphate, and the rest of them. So that leads to muscle relaxation and thus relieves bronchospasm. I will come again. Bronchospasm or bronchoconstriction is what you find in a person that has an asthmatic condition, right? There is bronchospasm. What is broncho? From the word bronchos, spasm is constriction. So I can say bronchospasm or bronchoconstriction. So now we're saying that what on the smooth muscles along the lungs, we have what PDE phosphodiesterase. So that's the name of the receptor. PD3 and 4. Phosphodiesterase 3 and 4. So this drug can bind to this receptors on the smooth muscle, it inhibits those receptors, which will then increase the levels of what? Cyclic AMP. So by increasing the level of cyclic AMP, it also brings about what? Bronchodilation. So the point was methyl-xanthines will cause bronchodilation by inhibiting what? Phosphodiesterase 3 and 4 found on bronchial smooth muscles, on smooth muscles of the bronchioles. Do you understand?
No.
So which part of that do you?
Methyl is that?
I said methyl-xanthines are a group of drugs called bronchodilators. What I also said was before the before the usage of these ones, what was used to relieve asthmatic or attack or COPD was what? A drug like what? Methyl-xanthines. Methyl-xanthines will inhibit a receptor on smooth muscles of the bronchioles, which was the PDE3 and PDE4, phosphodiesterase 3 and phosphodiesterase 4. By inhibiting those two receptors on the smooth muscles there, it would reverse bronchoconstriction and produce bronchodilation. Inhibits the enzyme, the receptor PDE, phosphodiesterase 3 and 4. It's an enzyme system, right? Enzyme linked receptor. Once it inhibits that enzyme, it will increase the levels of cyclic AMP. Once you increase the levels of cyclic AMP, it causes what? Bronchodilation, which reverses what? Bronchoconstriction, which is what we see in asthmatic condition. This is why we can use it for what? Treatment of what? Acute attack of what? Asthma. So saying what? It is related to, they are socially related to naturally occurring xanthines, like caffeine in coffee, your theobromine in tea and chocolate. So most of the drugs we use, they tend to relieve, they tend to look like things we either find in our bodies or that we consume as food. But now you are not getting it in a purer form and in a higher concentration. So there will be some of our food that contain nicotine naturally, but the levels are too small to cause you to have the effect we see in nicotine. So we have to give it a pure form to make you behave in a certain way. There are fruits like this, we call it, I was talking to someone about mad honey. I don't know something about mad honey last week. One week, leave us in class, okay, that's it. I said, we have brought with me. I said, we have pure honey, right? From your bees. I'm not saying about pure honey. The bee you found in your garden, you get pure honey, or the ones we give them food like pets. We have wild honey. This one, you go into the forest to go and get it. Wild honey is better typically than pure honey because there are it has a lot of herbs that tend to help the body heal. So they use it to mix medicine. Wild honey is more expensive than pure honey and it's scarce. But there's one thing that we call mad honey. You find in some countries, is it Vietnam and other countries? Mad honey is also wild honey. But the point is, the bees, they eat a particular plant that produce what we call that tend to distort your visual realities and your auditory realities. So since it's what the bee ate that came out in their feces in that, so it's not in a very, very high concentration that when you now know, I can give me that something I like to give me a bottle of honey now. I can just begin to lick. Lick to now what? You have licked honey, but you have licked a very, very high quantity of what? That plant I ate. I think that plant. So that plant causes you to hallucinate. Do you understand now? So if you want to, so when you get that, so it can produce an hallucination because of what the bee ate that is in the honey. So that one is even higher. It's even more difficult to find than what? Wild honey. So it's even much more expensive than wild honey. So that's what we call mad honey. You're not going to run mad. You may just display some symptoms and psychosis for some minutes. Then, if you tend to eat that plant, the fruit of that plant naturally, which used to be sweet. Even elephant, any animal that has, they begin to behave like something that's an animal. So they begin to. So that's how it was discovered. So a dog is behave like that. So that's why we discuss this. So medicines, right? So the drugs there that are used in this case are what? Our theophylline or aminophylline. So if I read from what I wrote here, so the most widely used xanthines are aminophylline and theophylline. Another related drug is doxyphylline, but basically we have what aminophylline and theophylline. They are mainly used as oral drugs. Oral drugs. So that's it. Now, these drugs are not given via the oral route. They are given via the inhalation route. You have to inhale them. It is inhaled. So route of administration here is not oral, which is what? Inhalation. So, but for medicines, I just said what they are given as what oral drugs for the maintenance treatment of asthma. You give it to maintain as a maintenance of what asthma, but can be used IV for the treatment of acute severe asthma attacks. Asthma gets levels. We have people that have what we call mild asthma. So maybe once in a while. Some people have moderate asthma. Some people have what we call moderate severe asthma. Some people have what we call severe asthma. We call it as status asthmaticus. Just like we have a status epilepticus. So they can have asthma attacks 3 or 4 or 5 times a day. I don't know severe. So for those ones, hello, please. Just be calm. It's not coming after you. So, for those that have mild asthma, your salbutamol or albuterol is enough for them. Once in a while, when they need it, call it what? When you need it. Some need it every day. A person has asthma, and this they are on admission. So you may have to give them aminophylline by IV infusion to stabilize them because your salmeterol or this one will not work. Probably for some minutes. Do you understand? So I just read what they are used for. So what? The drug is very effective, but requires careful use because of a very narrow therapeutic window. 10 to 20 microgram per ml. Plasma level have been desirable for bronchodilation with plasma levels above 20 microgram per ml, leading to a range of side effects. So the maintenance to give these ones, you give them between 10 to 20 microgram per ml. 10 to 20 for medicines. Anything above 20 can produce toxic side effects. Do you understand? So that is where you want to give. So 5 to 15 microgram per ml is recommended. Is recommended plasma level. More recently, with them showing signs of anti-inflammatory effect at lower plasma levels. Adverse effects are those related nausea, anxiety, tachycardia, arrhythmia, convulsions. This one when you drink a lot of caffeine, your blood pressure or you begin to skip a bit as if you fell in love or you broke your heart. Right? These things they can do the same thing. When you go over a particular level, the effect you see goes beyond your smooth muscles. You begin to see the effect on other systems. So it's not safe once you exceed that 10 to 20. So some people just say average 10 to 20, 10 plus 20 is 30, that might be 50. They also say around 15 to have a stable effect. So that is that. So I've talked about what your ipratropium bromide and your tiotropium bromide. These are the short and long acting drugs. So basically, I think I should stop here. I need to go and digest this, read up, then when we come out to do the other side, by the time I'm doing the other side, which is anti-inflammatory side, I will now finish most of the drugs, maybe it's one or two other drugs that we will use for lower respiratory disorders. So I've not touched upper because those don't tend to be mild. What I focus on is lower because you can't go to exam now and you say you did respiratory system disorder and they will not ask before the question must be an asthma or COPD. Before they remember rhinitis, cough, sneezing, There's always basic. Even you have cough as part of this condition.
Yes.
So you have to understand those drugs. Are we good? So please, I advise you, go and read up. On YouTube, there is a video about 20 minutes that explains all of these things. Just watch it one or two, if you didn't download it, watch it 1 or 2 times, and so you understand the concepts. Then we'll come back to do this whenever we meet again. So, thank you very much.
Thank you, sir.
See you. Now, your marker, it may mean that it's what I'm trying to say, or it may mean that going forward, maybe your Monday class will be like this. If I'm not going to teach them privately, if I'm coming to your class, this is the only way I can teach all of you together. Calendar now is too, my classes are too many now. So we'll be having extra classes. Even those doing revision now, 22A and 22B, I might be matching them together. I hope I still have data, Sha. Data didn't finish. I don't know. I have like 10 gig there, so I don't know if I will still have. Am I still live?
Yes, sir.
I thought you stopped it.
It's not stopping.
You don't stop it. But will you record?